Following the recent Trust and CQC assessment, some key areas for improvements were identified, whilst other key areas were shown to already be demonstrating good practice.
The first thing I would say is that community services overall were rated as good, and that's really important. Within all of these spheres of community services that were looked at, there was only 2 small areas that had requires improvement, so it's a fantastic result for community services. On the hospital side, we had requiring improvement as the overall heading for each of the 2 hospitals, Durham and Darlington. But if you look at the graphics, you'll see that the vast amount of things that the CQC saw and inspected and rated us on were rated as good. There are areas for improvement. These are areas we were working on, to be honest, before the CQC came, areas around A&E, areas around medicine, and areas that probably strategically we need to push ourselves further forward so that in the next 5 years we can have truly outstanding services across the board.
The Trust is focusing on 6 key themes where it was highlighted additional support might be required. Much of this work is already underway, whilst a plan for further improvements is in progress.
Some of the areas that they highlighted that needed improvement was around cleaning regimes. But we were already cleaning, but we didn't have the checklists to evidence that. So we quickly put that in place, and that's running smoothly. The other thing was around 24-hour domestics cleaning overnight, getting into all the areas, and that will be coming into place by the end of October. The paediatric department and the waiting room has to be visually and audibly separate from the main area, which is good, but it means it can't be watched by the staff as easy. So we've introduced CCTV into that area and the monitors on reception so we can look at everybody that's in the waiting room.
In A&E and urgent care, these key actions have already been implemented. While some work still needs to be done around these key actions, and this is progressing currently.
We've developed quite a comprehensive action plan in relation to the recommendations that were made. We have completed recruitment of a clinical service manager and lead nurse for palliative care and are currently aiming to recruit further consultants into the service. We've also enhanced the governance arrangements for end-of-life care. We now have an executive with board-level responsibility for end-of-life. We also have a lay member with responsibility for end-of-life, and we've enhanced the structure of our steering group, which now reports directly into Quality and Healthcare Governance Committee. Outside of that, we've developed an education strategy, an audit strategy, and have delivered 2 of our first training programmes to both medical and nursing staff within the organisation.
In end-of-life care, these key actions have already been implemented. While some work still needs to be done around these key actions, and this is progressing currently.
The actions around our service was about improving our governance processes. So we've previously we used to have a quarterly clinical governance forum, which was very well attended. It was a joint forum for Darlington and Durham, very well attended by consultants, senior midwives and the trainee doctors and some midwives as well. What we've done is we've introduced a monthly assurance meeting. So some of the more day-to-day mundane aspects of clinical governance we can discuss on a monthly basis so that we can put immediate actions in place from incidents that have occurred. But also it means that the things that are relevant to more of the junior staff can be put into the quarterly meetings to make them a little bit more interactive, a little bit more stimulating for people, and people can take home a bit more lessons learned from those kinds of meetings. We investigate incidents and people attend meetings and we write reports, but the actual staff on the ground sometimes don't hear what's happened out of these incidents and don't get the lessons learned. So we've introduced a couple of new notice boards around the unit. We're going to have an incident of the month or or incident of the fortnight, where we focus on a specific incident and we can tell staff exactly what's been done around that. And it's not just to be used for looking at negative incidents. We're going to be feeding back on positive things as well. For example, if something's happened, a clinical incident that's happened that's been really well managed, then we'll be able to feed back the learning points and show staff areas of good practice as well. Another thing that we've been looking at is our maternity dashboard, which is essentially an at-a-glance look at how we're performing each month. So we look at the number of vaginal deliveries that we have, the number of sections that we do, the number of babies that get readmitted. They're just a few of the things that we look at. Most units will have this information, but we've revamped it to make sure that the information that we're getting is relevant to us. It's things that we want to know about and things that we think are important for our women.
For governance and strategy, these key actions have already been implemented, while some work still needs to be done around these key actions, and this is progressing currently.
We had to get everybody on board to say, look, there are some issues, so we standardised with a protocol to say exactly what should happen to the patients wherever they hit the hospital, what should be the process through. We've also standardised the equipment, so hopefully that should be coming soon. So the equipment across the trust will be identical, including better monitoring facilities for the patients when they're on the machine. We've also done a lot of training, developed a competency framework for nurses and for the doctors so that we're happy that they understand what they're doing and how they're using the equipment. The next stages are around probably rolling out 4 times a year training sessions, so nurses and doctors will be trained together. So we'll have a multidisciplinary team approach to training, which I think will help because both nurses and doctors deal with these patients. So actually getting them into a room and doing that and formalising that training as part of the competencies they'll need to be updated every year. So that'll work. We're also working with a new simulation centre to see whether we could do something with them on the NIV programme, see whether we can use that, and that will again help. Because it's a sort of simulation of a patient, so you can actually go through the whole thing. We're looking at improving the units in terms of where the patients are based and sort of like the nursing support that those patients get, so increasing the numbers of nurses on those wards.
In medicine and non-invasive ventilation, these key actions have already been implemented, while some work still needs to be done around these key actions, and this is progressing currently.
We have reviewed and revised our documentation for the Trust, and this has been piloted on both of the acute sites and has since been implemented from August this year. Prior to the implementation, we trained staff in how to complete the documentation, and we also incorporated care planning into our preceptorship package with our newly qualified staff as well. To enable us to ensure that we were providing quality care and the documentation was up to date and timely and accurate, we've incorporated audited processes into the ward area as well. We've introduced e-observations, which is where a person who's delivering care to a patient is alerted when an observation's due. The person then carries out the observations and puts the observations electronically into a handheld set. This is actually time and date stamped at that point in time and is put against the patient's care record. It also has an electronic signature which enables us to have more contemporary documentation processes. We recognised that we needed to improve on our documentation processes. This included making sure that the documentation was timely, accurate and patient-centred, that it detailed the care that we were planning to deliver and also had delivered. We also need to focus closely on our care planning processes, as these need to be more detailed and had review dates added to them.
Around record keeping, care planning and ward management, these key actions have already been implemented, while some work still needs to be done around these key actions, and this is progressing currently.
We've been developing a standard operating procedure for our high dependency unit care within paediatrics. That is at the point of ratification. It will guide both our nursing and medical staff in critical care, and we're also developing a wider policy document to go alongside this.
and I'm here to give you a basic overview, a basic update for all staff around safeguarding children.
Safeguarding training, what we've been doing is reviewing our systems and processes so that we can capture our data more effectively. We've been working very closely with learning and development, and we've had a small task group established to look at what the blockages are and the waste in the system. Moving forward, we feel the guidance to the staff on the expectations of what they need to complete in the training matrix is going to be more specific, and we'll also develop systems and processes to inform managers specifically of staff that don't meet the training requirements from learning and development, so that they can be targeted effectively.
In children's and safeguarding, these key actions have already been implemented. While some work still needs to be done around these key actions, and this is progressing currently. In summary, 88 indicators were deemed good in the assessment, whilst 20 indicators require some additional support for improvements to be made. While some areas of outstanding practice have been identified, the key themes for improvement have also been identified, and much good work has already been done.
I'd like them to come back to really validate the work that I know that staff have done to take us to the next phase. We had our Quality Summit last Friday, and we were working with CQC and stakeholders on the action plans that we've produced, and it was acknowledged there that we'd undertaken a lot of the work, and actually we used the bulk of our time to look forward 2 years, and we set ourselves the challenge of being truly outstanding in 2 years to receive an outstanding rating from the CQC.